Good evening, ladies and gentlemen. On behalf of the Emirates Cardiac Society, I would like to welcome all of you, whoever is present with us in person, as well as the group who is joining us virtually in our session. This session is part of the global community initiatives of the European Society of Cardiology in order to address different aspects of cardiovascular diseases among the globe. Our distinguished faculty today will try to address similarities and differences in cardiovascular disease, as well as highlighting different guidelines in our local region. Without further ado, I would like to present the President of the Emirates Cardiac Society, Dr. Juwairiya Al-Ali, who is the first female president in second term to take the UAE Society of Cardiology. And she will show us today an approach to a complex Emirati patient with diabetes, palpitation, dyspnea, and lower limb edema.
Thank you very much, Dr. Safa, for the introduction. So we're going to try to make this a little bit more, approachable and easy to understand. We're going to go through a case, a very common case actually that we encounter in the UAE. And it's not a perfect case, but it's a real case, and that's the strength of it, because this is how a patient journey will look like in the UAE. These are my disclosures. So this is our patient. So he is 51 years, Emirati gentleman. He's non-diabetic for 4 years. He has a hemoglobin A1C of 7, which is not that bad. He's obese with a BMI of 38, and he is hypertensive. He's a smoker who refuses to quit smoking. And he has a family history of premature coronary artery disease. He has a brother who had an MI in his 40s, and his parents both had MIs in their 60s. And this is also not unusual for the area. We have a lot of patients who have family history of premature coronary disease. So he came in complaining of shortness of breath and lower lymphedema. And on examination, his blood pressure was reasonably controlled, 126/76. His heart rate was 62. So rate controlled, but it was irregular. And his chest was clear, but he had bilateral lower lymphedema. And his current medication that he was on atorvastatin 40. He was on bisoprolol 10 milligrams, dapagliflozin 10 milligrams, lircardipine 10 milligrams, pantoprazole, and perindopril 10 milligrams. So he did get an echocardiogram done, but because he's obese, the image quality was bad, so I didn't want to show you a bad image quality. But it was preserved ejection fraction, 50-55%, with mild LVH, but of note, normal left atrial size. And this is his ECG. So as you can see, he has atrial fibrillation with a controlled rate, and he does have diffuse ischemic changes. So you see this ST depression with T inversions all through. So these are his laboratory workup. So his NT-proBNP was elevated, 915. He had a normal thyroid function. His creatinine was 1.3, but because of his big body mass index, his GFR is 66.5. And his hemoglobin A1C, as we said, was 7. His total cholesterol was 164. His triglyceride was elevated, 314. His HDL was 29, which is reduced, and his LDL was 72. And he never had a microalbumin to creatinine ratio done. And this is actually one of the gaps that we see commonly in practice. People forget to order a microalbumin to creatinine ratio. In some of our registries in diabetes, only about 20% of patients have this done. And if we calculate his score 2 DM, his risk would be 23.5%, which is very high risk. So he's very high risk for cardiovascular disease over the coming 10 years. So this is his initial presentation. So I actually met this patient in 2025, but I'm taking you through the journey from the beginning. So he came on November 2022, and he got admitted for workup, given that he's a new heart failure and a new AFib. And he was complaining of chest pain on and off. And this is something that we see actually frequently with AFib patients. In Arabic, it's very difficult to say palpitation. So sometimes patients would say fluttering, and sometimes what they describe as palpitation sounds to other people as chest pain. So he ended up having a coronary angiogram, which showed just minimal plaques in the LAD, but no significant stenosis. And then he was discharged on these medications. So he was discharged on a amiloride hydrochlorothiazide combination, and bisoprolol 5 milligram, dapagliflozin 10 milligram, ezetimibe atorvastatin combination, furosemide, lurcardipine, prendoprel, and rivaroxaban as an anticoagulation. And he was advised for an outpatient sleep study. So, I mean, his therapy raises more questions than answers. So you would wonder, like, where are the 4 pillars of therapy for heart failure, right? He's missing some certain important medications here. Why not address rhythm control for this patient? Especially it's the first presentation of AFib, and he have a normal left atrial size. What about structured lifestyle intervention? This is a huge gap that we find. We find that patients either don't get referred for structured lifestyle intervention with a dietitian and a physical therapist, or if they're referred, they don't get to go there. And we had a study done in one of our hospitals that found out, so it was a patient survey basically. We found out that patients do not want to hear these advices from a dietitian and a physical therapist. They actually want to hear that from the physician. So a lot of this, there is a major gap in lifestyle interventions that we find. And then what about using cardioprotective agents for diabetes? So he is on an SGLT2 inhibitor, but what about a GLP-1 agonist? So this was all not addressed in the first presentation, and then we're going to see what happens to this patient. So what's unique about the UAE is that we have a rapid surge of cardiometabolic factors. These are data from the Waqaya program that shows that we have major cardiovascular risk factors. We have about 85% of the population are physically inactive. And maybe that's actually an underestimate, because literally people do not walk, people take the car everywhere, physical activity is almost non-existent unless someone actually makes an effort to go to the gym or to add physical activity to their usual life. We have high incidence of overweight, about 40%, 30% are obese, and as we said, sedentary lifestyle. The prevalence of diabetes is around 17 to 19%, according to which data set you're looking at. Hypertension ranges from between 23 and 32%, and we have 44% of patients with dyslipidemia, and around 20% of men are smokers. We have less incidence of smoking in women, but also these, the numbers for smoking are self-reported smoking. So it could be higher as well because there is a stigma related to smoking in the Arab culture. So we require extra vigilance when we're looking at patients in the UAE. We have younger population with premature atherosclerotic disease, premature heart failure, premature AFib. It's a very high-risk population with multiple risk factors that they all need to be addressed simultaneously. There is high prevalence of young patients with smoking, obesity, and metabolic syndrome. And patients are usually sedentary, and thus the true symptoms of coronary artery disease, peripheral artery disease, and heart failure are usually missed. And this is a challenge that we find when we implement international guidelines, because everything, if you look at heart failure guidelines, if you look at valvular heart disease guidelines or AFib guidelines, they're always talking about symptoms. But we have a population that does not do much. So it's very difficult to ascertain which patient who's symptomatic and which patient is not. And when can you intervene early to prevent complications, because patients generally do not do anything. I have patients in the heart failure clinic who will swear they're asymptomatic, and they're asymptomatic all through the year, except when they travel to Europe in the summer when they become symptomatic in Europe, because now they're walking, you know? So then he disappears and comes back in February 2024. And now he comes back with severe leg pain, and he's admitted as bilateral leg ischemia. And this is his CT angiogram. So if you see, the laser. So you see here in the middle, he had a clot in the descending aorta that was extending into the iliac artery. So he did manage to get the outpatient sleep study, and he had severe sleep apnea. He was prescribed CPAP, but he was not compliant to it, and he was not compliant to his other therapies as well. And that is was reflected in his cholesterol parameters, because when he was admitted with the limb ischemia, his LDL cholesterol is 163, so he's not taking his anti-dyslipidemic medication, and his triglyceride is 331. Again, his diabetic control is not that bad, 7.5. But given all the, he's a vasculopath, so he has lots of other vascular risk factors. So it's not only about the HbA1c, and this is what this case highlights. It's about all the other cardiometabolic risk factors. So he underwent urgent iliofemoral embolectomy, followed by lateral and anterolateral compartment fasciotomy, and he had a complicated hospital stay, which required multiple revisions for his legs. He spent 56 days in the hospital with this admission, and surprisingly, he never had a cardiology consultation during this admission. So he was discharged on these medications. So he was discharged on apixaban 5 milligram twice a day, amlodipine, bisoprolol, dapagliflozin, and furosemide. So again, lots of medications missing from his therapy, a long hospitalization that could have been a chance to optimize his therapy, but it was missed because he was not consulted with a cardiologist. So it comes back in May 2025. So at this time comes in complaining of shortness of breath and palpitation, had fast AFib with fast ventricular response, and so at this time, the team admitting him decided for rhythm control, so he'd underwent the transesophageal echo, but he had an LA clot. So they decided to treat him with rate control and discharge him with an outpatient TE. So this time he got discharged on better medical therapy. So he is on apixaban 5 milligram twice a day, atorvastatin 80 milligram, and ezetimibe 10 milligram, bisoprolol 10 milligram, dapagliflozin 10 milligram, and then eplerenone 25 milligram, prendoprel 10 milligram, furosemide 40 milligram, amlodipine 10 milligram, and then colchicine 0.6 milligram. The reason for the colchicine is because he was describing on and off chest pain, so they thought maybe there's an element of pericarditis. So 6 weeks later, he had a repeat TEE, which showed that the clot was resolved, so he was admitted for cardioversion. And then on follow-up, his furosemide dose was actually reduced and then discontinued. So remember, this guy was diagnosed 2022. 3 years later, we managed to get the furosemide off just by converting him to sinus rhythm. And a repeat Holter showed that he's now in sinus rhythm, and his NT-proBNP normalized. So now it's 86. Of course, his total cholesterol is better right now, but he still have a high triglyceride, and his LDL cholesterol reached to 56. So if you remember the guidelines, maybe that's a question you want to ask. The target is 55, and he's 56. Should we act on a 1? That's something for you to think about. His HbA1c is 7. So at this time, so we advised him to start on a semaglutide because he would benefit from that a lot, and also on icosapenthyl ethyl because he had hypertriglyceridemia. And at this point, because we thought his heart failure has been recovered because of the rhythm control, I thought simplifying his therapy is a target. So we switched him from single pills of bisoprolol, prendoprel to a combination pill. So that will enhance more compliance. And then we said we can consider his need for ablation after he loses some weight and demonstrates compliance to medication and CPAP. So you see, we have quite complex patients, but these complexities, if they're addressed quite early, can prevent further cardiac complications. And recognizing these problems and these limitations, Emirates Cardiac Society, in collaboration with the Emirates Diabetes and Endocrine Society, has worked on a combined guidelines. It's the cardiometabolic guidelines for the UAE. And it's addressing cardiovascular risk assessment and management in patients with dysglycemia. These are our steering committee, and we have Dr. Hani Sabur, who's the next speaker, who's part of the steering committee, who's going to take you more into the guidelines. But this guidelines recognizes that the root of all these problems is metabolic syndrome. It drives all these metabolic changes with insulin resistance and abnormal adipose tissue deposition that leads to the conditions of prediabetes and diabetes, obesity, and OSA, which leads to all these cardiovascular problems that we have at a younger population. And we have recommendations for annual screening and sometimes biannual screening according to the patient's risk. So I'm going to give the chance for Dr. Hani to talk to you a little bit more about how do we do this risk stratification in a patient who did not develop coronary artery disease. So in conclusion, patients with diabetes have multiple comorbidities, and it's important to address them simultaneously. Metabolic syndrome is a complex clinical condition that predisposes to obesity, OSA, and dysglycemia, and addressing metabolic syndrome early could reverse cardiac damage. Even in this case, like addressing it 3 years after reversed cardiovascular damage. So it's always important to look at the root of the problem and try to fix it. And before I end my talk, I would like you to book your calendar for ACC Middle East. That's happening in collaboration with the Emirates Cardiac Society in October this year, from the 3rd to 5th of October. And also for next year, I'll encourage you to book your calendar, send your abstracts when we announce for them, because next year we're doing our Emirates Cardiac Society meeting in collaboration with the International Society of Hypertension, and we would love for all of you to come and contribute to that meeting. And thank you very much.
Thank you very much, Dr. Juwairiya, for sharing this complex case. I think we will leave the discussion at the end after Dr. Hani's case. So next I would like to welcome Dr. Hani Sabur, who is the head of the prevention group of the Emirates Cardiac Society. Dr. Hani is a key figure in cardiovascular disease in the region. He has a lot of contribution through our local guidelines. His special interest is prevention, heart failure, as well as electrophysiology. And today he will share with us a case of post-MI in an Emirati patient with diabetes and chronic kidney disease. Dr. Hani.
Thank you very much, Dr. Safa, and thank you, Dr. Juwairiya, for setting the stage for this really important process. So this is my contact information. So this is really a case-based approach, how to screen and manage according to the UAE guidelines. So this is something I actually took from Professor Abdullah Shab. During COVID, we learned to be COVID doctors. At this pandemic that we are all living in, it's not getting any better. We all have to be CKM doctors. We have to be completely comprehensive and understand the risk that our patients are facing. So this is just a snapshot from the region. Dr. Juwairiya mentioned this, but this is a study that looked in the region of the prevalence of ESCVD and cardiovascular risk in patients with type 2 diabetes. 3,700 patients, 55 sites, primary and secondary prevention. This is what was happening in terms of their treatment, okay? Only 13% were getting GLP-1 and 36% were getting SGLT2. But the sad fact is, on the next slide, you'll see the problem, is that we have, can't see that. The achievement of any of the ESC guidelines in these high-risk cardiovascular disease patients with diabetes was, in all criteria, 0%. We were not achieving all the targets. And I talk about hypertension, only a third, and we talk about the dyslipidemia or diabetes. So we are not tackling even a quarter of the risk factors. Why is the risk increasing? Because we're not able to do that. So that was the PACMIA study. The UAE actually contributed about a third of the patients from the region. And you'll notice that if you take the patients in total, this is a snapshot, 37% are very high risk and 63% are high risk. This reflects the reality of Dr. Juwairiya's patient. They come to the outpatient clinic, they are unrecognized to be very high risk. And in reality, even though these patients, 99% were high and very high risk, only a third were getting disease-modifying therapy and SGLT2, and even less from GLP-1. So again, this is the rationale behind doing this set of guidelines with our diabetes colleagues. And in reality, I have to say we did the first cardiometabolic guidelines before the AHA actually came up with CKM as a concept in November. This is from January of 2023. We're many months ahead of that concept. So this was published again, all of you are in the guideline committee. So just want to highlight one thing, that CKM now is the overall totality of the same patient. I can't, as a cardiologist, ignore the kidney, the diabetologist can't ignore the heart, and so on and so forth. And all of these are interlinked because the inflammation, adiposity, insulin resistance leads to diabetes, hypertension, dyslipidemia, and subsequent complications. So the earlier we catch it, the better. Now there's two other diseases that are targeting here, which is also peripheral artery disease and non-alcoholic fatty liver disease, which is called MASH. So all the organs are being affected by the CKM syndrome. So in the center of it, in fact, this is an earlier stage than diabetes itself, is obesity. This is the core of all the CKM diseases. That's in the center ring. And on the middle ring, you see CVD, obesity, and type 2 diabetes, and then the complications as you wait longer and longer. So the earlier and more effective you work in the center, the more efficient the patient is treated from multiple different organ systems, and it's a holistic, multifactorial, person-centric, because it's the same patient having this all simultaneously. They're not separate diseases, and it's really the same patient. So in reality, this is the whole concept that we've been missing. As cardiologists, we've been snipping at this branch, the electrophysiologist snipping at that branch, the nephrologist snipping at the other branch. Nobody was seeing the whole picture. The real picture is you have a fat tree, i.e. a person with obesity. You need to attack it right at the beginning. That's how you deal with the problem. Dealing with the root of the cause rather than snipping at the branches separately. And we have to do it together. We all have to learn CKM as a language. Actually, this tree is native to Oman, in case you didn't know. So there is a regional reason for this picture as well. So again, these are the intertwined threads of all of this. So you have obesity, metabolic syndrome, hypertension, and as it progresses, all of the organs are being affected simultaneously, right? So the endothelial dysfunction leads to atherosclerosis, leads to microalbuminuria, which then leads to coronary artery disease, MI and stroke, and then macroalbuminuria. So the kidney and the heart are being simultaneously affected, and as you go further and further, you get into LV remodeling, chronic kidney disease, dialysis, sudden death, right? So where can we cut this thread? We can cut it anywhere, but it's much better to cut it early and upfront. I think that's really the key point. So this is a snapshot of the cardiometabolic guidelines, and you look at the categorization. So we wanted to label patients with type 2 diabetes, this is the higher risk patients, with cardiovascular disease or target organ damage. So they don't necessarily have to have an infarct to be very high risk, right? And then you can result in target organ damage. What's the definition? This is clearly from our guidelines. Proteinuria, CKD with GFR less than 60, LVH or retinopathy. If I see a patient with any of these, that's very high risk. So I intensify the statins, I add aspirin, I add GLP-1, I add SGLT2. All of it comes back to the same cycle. It's not just the nephrologist or the cardiologist everybody has to think about that. And then you can go slightly lower in risk. And we started to divide the patients, I don't want you to go through the whole algorithm, but by age and by duration of diabetes, because that's another risk enhancer as well. But just to say, looking at our patients in the PACMEA study, 99% were high or very high risk. It's not very difficult to realize that almost everybody's going to be in those red boxes. So you can go through this algorithm at your leisure in the guideline, but we wanted to make it extremely clear. Now, when you have a patient with diabetes, what is the ultimate priority of glucose lowering? It is no longer HbA1c. It's right there, irrespective of HbA1c. If they have ASCVD or CKD or heart failure, you must start with SGLT2 and or GLP-1 or both, right? If they don't, and the concern is weight, GLP-1 with CVOT benefit, right? Not all of them are like that. The combined GLP-1 GIP does not have this data. So we have, as cardiologists, to prefer this. And then, of course, SGLT2 inhibitors. You can use any other agent at any time as an add-on to then control the A1C, but you prioritize your patient with the disease-modifying therapies. It's very easy. So then the next step is, do they have underlying disease? How do I know as a diabetologist that the patient has heart failure? That's not common for them to make a diagnosis. Well, first of all, reduced exercise tolerance. And as Dr. Jouaira said, almost all our patients is sedentary. So what do you ask them? Can you go up one flight of stairs? A preemptive question. What happens during sexual intercourse? You must ask preemptive questions because they're primarily sedentary. Earlier symptoms are fatigue and tiredness, and most people attribute this to sleep apnea or simply not being conditioned. Lower limb edema. In the primary care setting, I'm not talking about cardiologists, lower limb edema in the primary care setting is often attributed to amlodipine. It's wrong. It's most likely heart failure. That's another problem. And what do? They add a diuretic, and they don't think about why, just like your patient. Next, ECG. So in our guidelines, I know it was a very small slide, but in our guidelines, an annual ECG and NT-proBNP are a must. Why? Because is this ECG normal? Now, we're all cardiologists, but when I show this to our primary care colleagues, I don't always get the right answer. This patient has LVH. LVH is the earliest manifestation of target organ damage. You don't need an echo. That's where it is. It's pretty clear if you start highlighting it on the slide. Now what else? There's other clues. Erectile dysfunction is a sign of vascular organ damage. Patients come to you complaining, asking for Viagra. The answer is, I'm going to give you a statin. I'm actually going to give you a GLP-1 and maybe an SGLT2 as well. So you have to look at the clues. And what about peripheral artery disease? So in our guideline, we've highlighted the use of ankle brachial index annually in all patients with diabetes. Why? Because diabetic patients are far more likely to have atypical symptoms that are attributed to B12 deficiency. And that misses the reason. And of course, a lot of these patients have a much higher risk of claudication than non-diabetics. And it's a very simple bedside test. You can actually have a nurse or a physician assistant do it for you. This reclassifies the patient automatically. This is the guideline. If your ABI is less than 0.9 in diabetes, this is polyvascular disease, you automatically go to very high risk. If it's 0.8 in non-diabetics, you're again very high risk. So it's very easy. You got to do it every year. This is a simple screening tool that has a huge value. And the reason why it's huge value is that it overlaps tremendously with coronary artery disease, cerebrovascular disease. You're picking up polyvascular disease with a simple bedside tool. And this is in our guideline. So what else? I'm sorry, I'm going to just skip through this. Also, the idea of heart failure. So heart failure is, again, a known complication of diabetes. And in our data, we took this 2009 guideline, applied it in the UAE guideline. NT-proBNP coupled with an ECG is extremely powerful in detecting these patients with subtle heart failure who are sedentary. So this way we can detect these patients, and this is in our guideline as well. So ultimately, you'll find that many of the patients in your region, in our region, are either high or very high risk already, in spite of being young. So we can't be complacent and not do the tests, and we can't be complacent and not put them on the right disease-modifying therapy. So the objectives of treatment in CKM are the following. Not just preventing coronary artery disease, but also extending to this. AFib, heart failure, especially HFpEF, peripheral artery disease and amputation, stroke and CKD, and now we also have liver disease as well. So risk management in these cases is not just LDL. It's way beyond that. We have many other therapies that we can utilize. So I know that was a long segue into the case, but now this is the case. So this is a case looking at a patient longitudinally. When could we have intervened earlier and what opportunities were missed? So this guy, see it? Okay, he's a smoker, obese, hypertensive, high LDL, and the original management was quite simplified, right? Simply lifestyle modification, an ACE inhibitor, CCB, metformin, and SGLT2 inhibitor. Now, what are his complaints? General fatigue, unable to sprint for even short distances. Does that bring up the idea of maybe coronary artery disease or maybe heart failure? We're not sure, but there's a symptom here in a young patient. The patient is obviously obese, so the BMI is 32.5. The A1C is 5.7. So the patient's not really diabetic, but they have a lot of the complications of insulin resistance up front. So we shouldn't be fooled by a low or normal A1C. LDL is sky high, it's 160. The physician says what? Lifestyle modification. Is this right, my friends? No. This is a big mistake. Just because you're young, our region has young patients with MIs all the time. So the guideline for us recommends many things. Early diagnosis, multifactorial intervention, early referral to cardiologists and specialists, and also glycemic control. So this is the actual guidance. Detailed history to elicit subtle symptoms. Don't blow it off as patients being not conditioned well, right? This is a very serious symptom in a patient with this amount of risk. Next, examination. Lower limb edema would be a clue. The presence of a reduced distal pulse, that's another clue. And now, this is why we're different than the other CKM guidelines. In the patients who have metabolic syndrome and not diabetes, like this patient, you screen them every 2 years at a minimum. In the patients who are diabetic, you screen them annually. So we've expanded it to pre-diabetes because that's earlier stage in our region, and that's relevant, I believe. And what are the tests we do? So this is sort of an expansion of the previous slide. Whether you do it every 2 years or every year, urine albumin-creatinine ratio and GFR. It's a must. In every cardiology clinic, we have to do it. In every diabetes clinic, we have to do it. And remember now, these are pre-diabetics. ECG is a must. NT-proBNP. This is really important because this is a biomarker of risk. We're not just pulling out heart failure. It's a marker of atherosclerosis as well. Ankle brachial index annually, and the annual eye exam, which is standard, plus the foot examination. Now, if the central tests are abnormal, you're going to refer to a cardiologist and do more tests. That's fine. But while you're doing that, you know what therapies have to be added because they become automatically very high risk. Yeah? So this was highlighted why we're doing it more aggressively, more early. And this was accepted by the government and the regulator and the insurer in order to help save lives and do things a little bit earlier. So that's actually the difference. This is side by side. This is the American Diabetes Association traditional assessment and our cardiometabolic guideline on the right-hand side. In the text, we also mentioned the use of calcium score in patients who are reluctant to undergo therapies. So additional things as well. So we include pre-diabetics, type 2 diabetics, and anybody with type 1 who's more than 10 years of duration, because those are already high-risk patients. And what are we doing? Symptoms and signs, ankle brachial index, we put it again in the physical examination so people don't forget it. This is a really important test, huge value over here. And then if you don't have any of these tests positive, we developed a score. Now I know this is something we've sort of abstracted, but hopefully when we develop the registry, we can get numbers on this. And you can put in the score based on age, duration of diabetes, number of risk factors, and if you have multiple risk factors, you become very high risk. You get a score of 4. So if you screen negative on the physical tests, you can still be high risk or very high risk based on a scoring system. And that's the whole process that we highlighted here. So is this patient likely to have underlying cardiovascular disease due to obesity and CKM? Yes, you're very suspicious now. Now you're getting worried, right? So what do we do? What do we do? So the ACR in this patient is high, 174. Anything above 30 is already a high-risk patient. Why? Because they have renal target organ damage, which is equivalent to cardiac target organ damage. The patient also has a calcium score of 329. That puts them right into the ASCVD. This patient has not had an MI yet. So what are we going to do? When you have CKD, you add what? SGLT2, GLP-1 receptor agonist. If you have ASCVD, based on your calcium score, high-intensity statin, lipid lowering as well. So these are the things that need to be done to this patient. Unfortunately, it wasn't. So just to remember, all of these factors overlap. The CKD and the CKM are part of it. We can't ignore the fact that the same risk factors for CKD are the same risk factors for CKM. All right? And why does it happen? Mostly, sorry, there's too many innovations here. Because kidney disease causes rapid progression of cardiovascular disease due to oxidative stress and inflammation, so it contributes to systematic inflammation. And if you look at the classification of CKD here, your CKD change simply to CKD3 increases your mortality by 30%. So this is why we have to be very attentive to the kidney as cardiologists as well. And this is a huge table that shows all of the things that you can do to address the residual risk, which means that the CKM patient is not a quick visit, refill the sulfonylurea and metformin. It's going to be a detailed visit. What are the gaps in this patient's therapy? And the two biggest ones that we miss almost all the time are addressing obesity as a cardiovascular disease and addressing kidney as a cardiovascular risk as well. And we have tools now. We have therapies. That's why we're talking about them, specifically with semaglutide, dulaglutide, and also addition of finerenone. So just a quick one point about weight, because as cardiologists, we really have to get deeply into this science and be attentive to this problem. In the SELECT study, which was a cardiovascular outcome study, the BMI was over 27. They were not diabetic. They all had ASCVD. Regardless of the baseline body weight and regardless of the change in body weight, whether it was more than 5% or less, semaglutide reduced cardiovascular events, MACE, and hard endpoints by 20%, and the endpoints accrued within the first year. So we can't ignore the patient with obesity who comes to us with an ACS. This really has to be a must in our treatment, and this is the difference. Placebo weight loss, more than 5%, semaglutide weight loss, less or more than 5%. The difference is caused by semaglutide. It's not caused by the weight loss, right? But we have to use this as a biomarker. Why does this happen? Largely because of impact on C-reactive protein, triglycerides, and other inflammatory parameters. So this is also something that we are finding uniquely different with each test we do. So now the patient reports chest pain and is finally referred to a cardiologist with angina pectoris. Ends up having a myocardial infarction. Of course, the initial treatment is identified. The patient undergoes a successful PCI. But should they go home on a GLP-1 receptor agonist? Yes. Tell me how many patients you've discharged last week from your coronary care unit on a GLP-1 receptor agonist. Haven't done it. And that's the SELECT study. And that's something that's now in the guidelines. So the reality is, why are we talking about obesity in a CKM syndrome? lecture because it's essential. It's another 20% reduction of events in patients who are on maximum medical therapy. And the SELECT study showed that the MACE reduction was, regardless of the baseline adiposity, independent of the weight loss, and therefore the alternative mechanisms, and patients even who didn't lose a lot of weight had a very powerful outcome. So atherosclerosis is being arrested here. And this is now a snapshot of the most recent guidelines from last year in CCS patients, semaglutide in BMI over 27 or obese CCS patients without diabetes, and certainly any patient with diabetes who has cardiovascular disease has to be on the GLP-1 receptor agonist. It's obvious because it has cardiovascular outcome. So what happened to this patient, really? The patient had increased dyspnea. EF drops to 25%, now is on GDMT for heart failure, and unfortunately the patient has a second MI and dies of a cardiac arrest. This is the lethal outcome of inertia. We have tools to detect, screen, and treat. We need to apply them early and effectively. So thank you very much for listening to me. And this is another plug for the Emirates Cardiac Society ACC Middle East meeting, basically next month. And also the International Society of Hypertension, Emirates Cardiac Society next October. Please join us.
Thank you very much, Hani, for such an elegant presentation that highlighted how complex the patient can be, the diversity and the differences in our region. We'll move into the third talk, not really presentation. Dr. Abdullah Shab, who is the Vice President of the Emirates Cardiac Society. He's an intervention cardiologist who will highlight to us some important differences and similarities, as well as highlight some important things in our local guidelines from the two cases that has been presented.
Dr. Safa, thank you very much. Dr. Hani, Dr. Juwairiya, you highlighted, a real painful cases. I mean, this is a bit extreme. I mean, most of the cases, I hope not like this, but this shows where the overlaps. Young patients having comorbidities, overlapping with polypharmacy, overlapping with poor adherence. So our job, of course, to simplify the regimen, in addition, of course, to other things. So then you showed us, what we have in the country. We have everything available. I mean, all the investigation you need is available in UAE. All the medication first to be registered is available in UAE. So the Dr. Juwairiya, you showed us the patient who end up, 56 days, I don't know how many days, not seeing a cardiologist. I mean, this must be a problem in the system, isn't it? I mean, it's not an individual thing. It's in that hospital or whatever hospital, something happened. I mean, we learn something from that? I mean, for future, we don't want to miss somebody at young age, not to be on appropriate medication, appropriate directions for management. Of course, you've kind of end up at the end, the right place, and you managed to do that. And the same apply to Dr. Hani's. You showed us the patient who are again young, had all the comorbidities, not been addressed earlier. Some of the risk factors should be highlighted and prioritize the medication, which not happened. And of course, patient had heart attack. And maybe as an interventionist, maybe I'd be interested more in lumen than the holistic patient, which is wrong. I mean, we learn from each other. I mean, not to work in silo. I mean, we should work in together. That's why the cardiometabolic initiated, really to bring us, we are physicians, we are learning from each other. So really, I just want to highlight that and to see what we learn from these cases and open it for you as well as, the audience.
So yeah, I mean, I was shocked about the 56 days of admission and no cardiology consultation. But I mean, there is two things to think about in this. One of them is, I doubt that they didn't call a cardiologist. But a lot of, think about it, a lot of the people who are receiving the calls in the hospital are our frontline young cardiologists who deal with the MIs, who deal with the acute heart failure, and having to address the CKM pathway is not it's not their daily practice. It's usually the daily practice if someone is sitting in the clinic. So maybe it was a phone call to someone who said, yeah, this patient is not in acute heart failure and his AFib is rate controlled, we'll deal with it on discharge. And then that was never addressed again. So you're right, it's a system problem. But it requires more education for our younger colleagues in order to address these things, because that's an opportunity. You might lose the patient if he leaves the hospital and never comes in for a follow-up. But we also have to understand that that's going to be also a burden on the system if we're going to receive a call for every single cardiac patient who gets admitted with a surgical problem. So as I said, it's a double-edged sword.
So I think CKM is a mindset, right? It's not a special clinic. It's just how we start thinking differently about the patient. So I see a patient with AFib. I'm also thinking about their LDL. I'm wondering about what's their BNP. I'm looking at their HbA1c, because ultimately you can prevent their stroke by giving them anticoagulant. But if you leave everything else, you're not going to help them. And we just saw the analysis presented yesterday of the SELECT outcome study that showed reduction in atrial fibrillation. So isn't that amazing, right? So I think we really have to step backwards and remember that we're all primarily clinicians and medical doctors and cardiologists, and now we have to have interests in other things. So if we have a broader horizon, I think we'll be much better. And I think cardiologists do this very well, because we see patients across the spectrum. We see outpatients, we see intermediate patients, we see sick patients. So I think we can do this very well, and I believe this is how we lead the process from the cardiologist's perspective.
Why an MRI was not considered in the heart failure case? Your case was case.
Yeah.
Never at the stage of treatment, an MRI was not finerenone or any MRI.
At the end only. So
The end only, yeah.
yeah, at the end only. So like it was missed the first time, it was missed the second time,
subsequent.
only at the end that it was.
Even when amyloid hydrochlorothiazide was shattered
That's it.
also, at that point also an MRI was not considered actually. So
Yeah. Yeah, so this is a major gap, right? Like someone, it should be on top of your head, but sometimes these things happen and people lose focus on other things, right? They focused on rate control for AFib and forgot that this is a heart failure case. So that's the complexity of the situation. Yeah, Victor.
Yes, Dr. Ayman Smair, cardiologist. Thanks, Dr. Hani and Dr. Jouaria for this nice presentation. When I moved to the region 2 years ago, I was shocked with the amount of how advanced cardiovascular disease in the region, especially in younger population, and the inertia that we have physicians, particularly cardiologists, to adopt new medication that has been proven to improve outcome. I remember my practice in the US in the 2020s when the ESC inhibitor showed clinically that they improve outcome cardiovascular disease. Still, as a cardiologist, we didn't feel comfortable ordering this medication. And now I think every cardiologist is comfortable. Now I still challenge, I think, with the GBL1 agonist. So I think there's a lot of work to do, and we need to spend more time around the tree, right? I think the concept of the CKM is very important, and cardiologists, we have a role to lead that. With the guidelines, I'm going to challenge you, Dr. Hani, about one thing you mentioned, because the major scientific society, they don't recommend for the annual ABI, and I'm sure like you guys have a good reason to come up, so it's good to understand the science, the logic behind it, because now people, would hear one different presentation, then they go back and they see, guys, there's something missing. So just make sure highlight that and give us opportunity with the thought process. Thank you.
Sure. So our guideline is actually very much tailored to the local community, right? When you see how people are sedentary, so they don't have claudication because they don't walk. Actually, there was another case, we didn't have time to go through it, but the key point is when people don't walk, you can't elicit cardiac or vascular symptoms. The second thing is if you look at the risk that comes from an abnormal ABI, so the risk is actually 6-fold. So it's actually more powerful, if you think about it, than a coronary CT. So by putting that in the forefront of patients who actually have diabetes, or in our case, see, I've learned that prediabetes is an irrelevant diagnosis. These patients just have a difference in A1C, but in those 5 years, they have the same risk in terms of insulin resistance and in terms of high blood pressure and in terms of cardiovascular events. The only difference is this fake definition of prediabetes, which gives people inertia even more, right? So that's why we took a pragmatic approach to deliver that to the patients who are technically not diabetic. Now, the American Diabetes Association has recommended ABI screening in patients who are deemed at high risk. Well, how do you know they're high risk without doing the ABI? So typically, the duration of diabetes comes into it and the risk factors. So this is a pragmatic approach simply to have more patients in, and we realize that the cost to the healthcare system is minimal. I mean, we're not talking about a PVR, ABI, or an ultrasound. This is simply get your nurse to check the blood pressure in the ankle and check it in the arm, and that's it. It's a 2-minute thing. And we've actually, I think our colleagues at ICLDC have been looking at this. They've been doing it for 5 years now. The numbers are staggering. that are abnormal. Now, not abnormal to send to the vascular surgeon, but abnormal enough to change the treatment. So they relabel the patient, and they don't have access to coronary calcium score, so they use that as the surrogate. Thank you. It's a brilliant question.
I think there's last question. Go ahead.
Yeah, hello, thank you very much for the very nice presentation. I have one question, please, for the screening. We talked about how important is the screening by the patient for patient, which the difficulties are by asymptomatic patient.
Sure.
Doctor explained us very well that the patient doesn't know that they have symptoms. How can we push this patient to consult
Yes.
by a family doctor or a cardiologist? And the second question for Dr. Hani for the lifestyle, is there a possibility, like for the population in Arab world, I will say, the lifestyle can be challenging, but for a lot of people it's better than take medication.
Sure.
Can we trust our patients when they told us they want to do a lifestyle adjustments, and if we want to give them a chance to do these adjustments, how much time can we wait?
Sure.
Thank
very
you very
briefly,
much.
Doctor, because we're over time, but be very briefly. Answer the
Alright.
question.
So you go ahead. And I'll
Okay. So, I mean, to elicit the symptoms, you have to dig deep in the history. So, can you take flight of stair? How was your sexual activities? How much can you walk? Do you find any limitation? Most of the time, they're not going to answer all these questions. Nobody takes stairs, they take elevators. So you need to test it. You need to test it somehow. So this is what I do in practice. I know exercise testing is not recommended for asymptomatic patients, but we do not know that these people are asymptomatic.
Truly asymptomatic.
So we do send them for exercise testing. Patients who cannot do exercise testing,